So let me tell you a little something about this session tonight. So if you, we switch to the actual show. So you're going to see us go off because you want to see this in full screen mode. There it is right there. Okay, so what we have here is a multi-camera view of everything happening in the operating room during the procedure between the surgeon and the perfusionist.
And anesthesia.
And to some degree, well, yes, and anesthesia is included. I'm not excluding them, but, you don't see anesthesia in this. So, that's true. But for my anesthesia brothers out there and sisters, yes, you are included in this, but he just can't see you. Maybe next time, Patrick, you can add some more cameras and we'll do anesthesia too. But here's the operative field, exactly. And you get to see a lot of the operation here. Here is the hemodynamic monitor. So you've got the EKG, you've got the arterial waveform, you've got the pulmonary artery pressure, you've got the CBP, you've got the pulse ox, and over here the relevant numbers that are associated with what those waveforms are showing. And then down here in the left corner is the oxygenator that you're going to see there. And then here in the middle, man, this thing.
I've never seen that before, Joe.
I know you probably never have because you're right here because that's Dr. Mettauer's back. No, I think it is. Yeah, it's Dr. Mettauer's back.
Looks.
Or Dr. Maniscalco.
Dr.
Yeah, that's right. The black scrubs. Okay, let's just turn this thing off. That's not working. And then to the right of the oxygenator, you see a panel, and that is the heart-lung machine perfusion panel. And then to the right is the actual heart-lung machine. And what you see there is the main arterial head, which is to the left there. And then you have the cardioplegia, the pump suckers, the root vent, and the LV vent. Now, we don't always use all of those. We use those depending, but we always use cardioplegia. We always use the sucker, and we're always probably going to use a root vent. The LV vent is for valves. And I think in these cases, most of them, the two of the three we show you, you're going to see that. Now, like everything else in life, so let's switch to the other screen. Like everything else in life, this has been an evolution. So when we first started out, and I got a telephone call. Here, can you go ahead and project us? I'll tell this story real quick, and then we'll go to that first one. Can you put us on live?
Yeah, we're on live.
No, us.
We are.
Oh, we are. Okay, so program out YouTube. Oh, okay. Yeah, I don't even know what I'm looking at here. I'm looking at the top one, not the bottom one. I'm sorry. So I got a telephone call yesterday, from a lady named Adrian. And I answered the phone, and she said who she was. She had left a message. I called her back. And in deference to HIPAA and all that, her father was one of the cases that we did, one of the first cases, in fact, that we did. And we'll call him Mr. B. And Mr. B actually runs a radio program, a podcast program through YouTube, and it's called Weekly Politics in Montgomery County or something like that. I don't know if you've ever heard of it before.
No, and she recognized him through the video.
No, well, they got Patrick got consent. No, when he
okay.
consented.
Right.
Yeah, when he got the consent.
I'm just checking.
Yeah.
I was trying to figure out how we're violating.
No HIPAA violation. No HIPAA. And so, Mr. B, if you're watching, you can either text us, call in. Adrian, if you're watching. But when we first did it, you'll notice that we're missing that panel for the heart-lung machine. Can you point to that for me? Go back to that and point to that for me. Yeah, that panel that was there. So the early cases we did, we missed that. But so in Mr. B's case, it's not there. But this is actually Mr. B's case. So let's play just a little bit of this. And while it's running, so what you see there, Mr. B, is your heart. And Dr. Maniscalco is putting purse strings in. And on the right side is all of your hemodynamic monitoring. And on the bottom left, you see the oxygenator, which is where all your blood went through. And we oxygenate it and stuff. And then to the right is the heart-lung machine with the various pumps spinning. So can you fast forward that a little bit and just go ahead and get to the going on bypass phase? Which was that, Patrick? You might have the number.
Yeah, that one is
325.
Yep, 3 minutes.
3:25. Yeah, 3 minutes and 25 seconds. So we'll fast forward on this a little bit.
I haven't seen a right atrial appendage like that in a long time, Joe.
Really, I know. It's exciting.
Beautiful.
It is.
Easy to fix if there's a hole in it.
Yes. Oh, here, look. We're going on pump.
Oh, there you go. Reservoir getting
Full.
filled up.
There you go. Mr. B, there you go. Right now, Patrick has a look at your hemodynamic monitor. But for
Look
those,
at your heart, you know,
hearts
are shrinking
it's,
up.
It's empty. It's shrunk. Yes, I'm glad you're here.
Yeah.
I've never seen a heart do that before.
You're right.
I've never
Yeah,
in my
all
life.
you ever see is that red line running.
That's all we ever look
got a
at.
phone
That's
call coming
it. So, somebody's calling in. Let's see.
Already? Wow.
Hello, you're on the air. Oh, emergency alert.
Ah, is it that new
This is
national
a test of
presidential?
the, I don't know what happened. I don't know. Here, let's see. Let's see who that was. I don't know what happened.
Did everybody
there.
get their alert yesterday?
Yes, I got it.
Yeah, like 6 phones went off in the OR. It was great. Scared everybody to death.
Can somebody help me with this phone? I can't figure it out.
Well,
Here, I got it.
in the
Here.
meantime, David, can you skip on up to when we arrest Mr. B's heart? That's because that might be kind of cool for him to see. That's 4 minutes, 57 seconds.
Let's see here. I'm calling him right now. Calling this number back.
So basically, you're on bypass now, but your heart's still working. So,
Yes.
and we do heart surgery like that sometimes, don't we, Joe?
Yes, we do sometimes. But this is exciting stuff. Has anybody here ever seen anything like this where you're seeing and these are all synced together, right, Patrick?
Yeah, they're all the same. You could never see this.
Look at
because-
the ice going on the heart.
He uses ice.
The cross clamp is going on. I'm gonna beat you. I'm gonna beat this guy.
Sorry.
Okay. But so Mr. B, there's the ice on your heart. Let's see. I guess this isn't gonna
Notice
work.
the
Hopefully they'll
cardioplegia head
call
is
back.
turning, and you can see that the heart's going to arrest here in a minute.
I use ice too, Mr. B. Just saying. I'm just kidding.
We have one of your cases on here too. Don't be so jealous of Dr. Maniscalco. Why are you so jealous of him? All right, so let's go ahead and bring us back live. But that gives you kind of an idea out there in web world what it is that Patrick has really accomplished here. So Patrick, I'm going to turn this over to you now and let you kind of go forward with this show.
I've got some people to thank and all that, but so we
I'm
filmed.
included.
Yes,
Oh,
you
I
are.
get
We
that.
filmed.
Please don't.
What do we film? 10 cases, and the scope of this was pretty big. We actually ended up with 6 terabytes of material to
Holy
edit
cow.
down, and hours of time on that. So, but I do need to thank a few people. I wanted to thank Joe for providing the resources to do this, because something like this, you can come up with an idea like this, but who would actually do it? And you provided the people and of course the equipment in the studio. And I got to thank Dr. Maniscalco and Dr. Mettauer for allowing us to film during the cases, which was really nice of them. I want to thank Roger Ramirez, who did the camera work in the operating room. I've got some pictures of how we did this. We'll do that in just a minute. And then David Sullivan, he did hours and hours of editing on this as well. He's our person running the board back there. Can we take a minute and pull up those production photos one at a time?
Oh, yeah.
So we can see how we did this.
Yes.
We used GoPro cameras on a couple of different areas of the operating room. You'll see there that the nurses were kind of more interested in looking at our equipment and our films than the actual surgery. That's how nice the pictures were looking on the live stream when we did that. So that's a couple of nurses looking at our live stream. All these cameras were they recorded simultaneously into this machine, the live stream. There's a picture of Roger with the camera. He's got the camera on a boom, which he uses that to kind of get right down into the heart, where he can get good pictures and zoom in and follow the action at the table. And there's a picture here of one of the GoPros. That's the one you're seeing on the pump. We flipped that image over because it was upside down. We also ended up flipping the image of the heart, because that way you're seeing the perspective of what the surgeon sees, not what the anesthesiologist sees. I think that's all of our pictures. Oh, there's a picture of the GoPro that we have on the reservoir. So that's how we did this.
How long did it take you to set that up, Patrick?
In the OR?
Yeah.
Yeah, Roger came in and did the feed from the vitals first the night before, make sure that all works.
wow.
And then from
Because it
there,
didn't slow me down. I was just
oh no, we were
curious.
there
That
early.
was-
It's about an hour
Pretty cool.
to test everything and all that. So the goal of this project, I think you had some ideas of what the goals were. My goal, I think, was that we would hopefully have a better understanding of how we as perfusionists affect what the surgeon is doing at the field more precisely, and also perhaps that the surgeon would understand a little bit more about what we do and how it affects you. And I'll tell you, from editing these and going through these films, I have learned an enormous amount. In fact, you told me you're doing a better job. I'm not sure why, and it's because of looking at these films over and over and over again, because we've got them all marked up as to what each part of the surgery. So that's where we're at. We can go into a really big case that you had. It was an aortic valve. Well, it was an aortic root replacement was the original idea, and then the valve was not working, and we went back and replaced the valve as well. So that's our biggest surgery.
And that is a big case. I'm curious about something because, you saw that the nurses, they're like, they're the circulators, and they're just looking at all of that stuff. Now you circulate and scrub,
Yes,
so
sir.
you do both. So what's your perspective on this? In other words, as either not being a perfusionist, not being a heart surgeon, not being maybe anesthesia, from a nursing perspective, what do you think about this project?
I think it's awesome. We could use it so much for teaching for our nurses staff when we're learning and training to scrub. It's so hard to really describe to them what they're going to see up there and what they're going to do up there and what they're going to hand and why they're going to hand it and what he's doing while I'm doing this and what I need to expect next. My job is to expect what he needs
Anticipation.
and to have it before he needs it. And it's very, this would just be awesome to train because they'd be able to see that so much
And
better.
also having a perspective of what we do. But I think you could
that's just a nice corollary to this. 'Cause
Yes.
I didn't even think about that till she just said that.
right, but would it also be
Because
really
there's some
neat?
guys that get it. Shelly gets it. There's a handful of scrubs that get it.
Yeah.
But there's some that need an extra time on the learning curve.
Yes, but I
This
think
is super easy.
wouldn't it be cool to have the back table being videoed
I was just
with the field?
I was just about to say that.
Yeah, exactly. I
That
was
would be
thinking
good.
it for.
Yeah.
I read your mind. Okay,
Way to go, Shelly.
Sorry.
way to go, Shel.
Seriously, I just thought of that. I mean, she thought of it, but I mean, it's a great. I didn't think about it before. So
Yeah, I think it's fantastic. I think this has so much potential, like because you see things usually in a vacuum, right? You see one thing that you're watching. If I'm standing there watching you operate, it's fascinating. But and it's neat. I mean, it's pretty cool what you do, but it's not in a vacuum. Right. You're doing that because of all these other people, and then what I do may affect her. What she does could affect me. Just understanding how the venous line can be obstructed and the heart's blowing up. I mean, it sounds silly, but I mean, I know it's a simple example, but little things like that. What can we really all learn from each other? And that's kind of the idea of Dr. Lumsden's, Pumps and Pipes thing, which I've promoted. It really is a very good conference, but where you're looking in the other person's tool chest. If you can see the whole thing happening in front of you in one screen, how many ideas will come from the ability to associate this with that you ordinarily don't get because you usually watch things at one thing at a time, not all together.
Well, in this film, actually, you couldn't see this all. I can go watch the surgery or I can watch the pump. I mean, if I'm not the perfusionist, I can watch the surgery. But you can't watch both at the same time. And you can't do that and look at the monitor. So there's no way to do this other than the way we did it. I'm going to ask a question. I would like you to be kind but honest in your answer.
I can do that.
Okay. Because it really opens me up. If you didn't hear the perfusionist or see the perfusionist, would you know who's running the pump? Are we different enough to affect your surgical field, I guess?
Some of you are.
Okay.
Yes.
So-
And that's just comes with anticipation. Usually it tends to be from a more experienced perfusionist, but I can honestly speak that there's some guys that have been doing it for 20, 30 years that you got to outline every step and communicate loudly, and it's more effort on my part. I mean, it may not appear to be more effort, but it's like I've got to turn around. It's not from this particular group that I work with. Joe is...
Be kind.
No, I am. I've kind of been the proving ground for a lot of your guys. And, as crazy as heart surgeons are typically, and I'm pretty outspoken and a little bit verbose, and I think I'm pretty fair.
You are.
But I'm also pretty black and white. I mean, Patrick knows exactly where he stands with me. I mean, he came out of sales for a while, right? And his learning curve was better than what I would have expected from where he started. And I've made comments that he's doing as well as your probably most experienced, Mike Brown. And that's because he actually cares. And there's some guys that just want to run the pump. Honestly, I think there's some guys that just don't get it. And I don't know why that is, except maybe this could be something that would help them.
Maybe. I think you're bringing up a real. That's a.
That may be a lot.
Session.
That may be a lot. That may be a lot
Yeah,
to
that's
ask.
a lot to digest. But I will say that.
The short answer is yes. I can tell typically who is behind me.
Okay.
At least I can categorize them into people I don't have to worry about.
Yeah.
Versus people I've got to stay a little bit more on top of. But your current group, which is pretty sizable. The weakest link is very strong. Let's put it that way. And that's no joke, because you and I have had our talks about certain individuals that
just
weren't going to cut it and were unsafe.
Right.
Well, they were unsafe.
Yeah.
And if they were with any other surgeon, the surgeon would have panicked or whatever, and it could have had a bad outcome. You got to be able to communicate and troubleshoot together as well.
Absolutely. Hello, you're on the air. This is Joe Basha. Hello? Okay, I don't know what's going on, but it's probably spam calling. Okay, so let's just turn this off. Turn the phone off until we go phone lines open. That's it. I will say that you are very good. You've gotten better at apologizing. So you do, sometimes you have done a lot better with that. I'm proud of him for that. Let me tell you something right now. Okay, Patrick, I'm sorry. Continue,
No, that's
sir.
okay. Yeah. I'm going to ask one other question before we get started too. What would you, and I know your answer, Joe, so just hold your answer. I know what you're going to say.
I'm zipping it up.
What would you say is the job of the perfusionist? Like, what's the core of what we do for you?
To make my life easier. And by that includes a lot of things. It's a simple answer, but it's essentially, if you're on pump, to have a cold, still heart that doesn't move and
Bloodless field
that's within your capabilities of performing, and it doesn't always happen. There's you move the heart around, etc. There's things that I cause that I realize that make it difficult for you as well.
Yeah.
But just basically to make, I really want you to be, not that I don't care who you are, but make it to where you're kind of in the background.
Yeah.
You're a good supporting cast, so to speak. And that's not an egotistical comment. It's something, that's one less thing I've got to worry about. Anesthesia is another component I got to worry about. Because if I got new people I'm trying to teach how to do heart surgery, which I'm doing right now, that's what I'm focusing on. And if I got to start worrying about what's going on behind me, that's a whole other issue.
Yeah.
And so right now, my personal practice, I'm in a great place where I don't have to worry about that.
Now, I will say that I, to some degree, disagree with you.
Okay.
And I really don't believe that the perfusionist nor the scrub or circulator or whomever may be in the room should really be necessarily out of sight, out of mind, and just make this do what it needs to do so that so it's what I need. I really think that everyone should understand as best they can. I mean, I'm never going to be able to do heart surgery. Shelley is never going to be able to do heart surgery, but we can.
You're making my point though, Joe. You know why?
Why?
Think of a football team.
Yes.
If you don't have a good offensive line, because I've got one in my family, my kid,
Mm-hmm.
nothing else works.
That's right.
So consider you guys kind of like the unsung heroes, because if you guys don't do well, it's a you know what show.
But yes, it is. But my point is, how many times do you see an offensive lineman, the center, going up there, and he starts pointing, he starts doing things. He's not just he took the orders and going to hike the ball. He's seeing something that he needs to communicate. So, my point is that I think, no one should be, and I understand what you really meant, but because I do think that has to be done. It takes finesse to be able to do that. It takes some experience to be able to do that. To be a facilitator, to see things and to help you, as opposed, because sometimes we need to communicate. We have to be able to talk to you.
But I think for the most part, y'all see problems that are coming up that I don't even realize and take care of them.
Mostly, yes.
Because I'm not a guy that watches the arterial pressure all the time.
Right. So who
is you and anesthesia?
What are the two worst words you never want to hear?
Well, splat and then oh crap.
Uh-oh. Yeah. Uh-oh.
Yeah.
Uh-oh's bad.
I heard that one time when the venous line came detached from the pump.
Uh-oh.
Yeah. And that was pretty scary.
I'm sure it was.
All right. Well, we have, this is the second case, right? This is the Dr. Mettauer case. All right. So we're half an hour into this. We got to jump in. We have a lot of
go ahead.
material.
I'm so sorry.
We may not get through all the cases, but we have lots of material.
Try.
And,
we're going to try.
We're actually going to, yeah. Okay. So at 1 minute and 30 seconds is when we go on pump for this. And we actually kind of just showed that, so we could.
I'd show it again. Okay. I would. In fact,
it's a different.
I would go over all the different little pieces and talk about each piece.
Well, this is well, we already said it's an ascending. It's a root replacement originally, and then we had to go back on and replace the valve.
Which by itself, a root replacement is really not that big a deal, but it becomes a bigger deal.
Yeah. So what I was trying to do is preserve the native aortic valve because the leaflets were fairly normal in appearance on the TEE. And so the plan was to tighten up she's an older lady, so we want to make this really quick. Tighten up the sinotubular junction. Sometimes simply doing that can allow the leaflets to coapt better. Mm-hmm. And you'll see that we gave it a shot. It looked pretty competent. With our saline test, and then we repaired or replaced the ascending aorta, and but on TE afterwards, it just really didn't look so great.
Mm-hmm.
I was wrong. This is cannulation. We can look at that if you want.
No, let's go to.
But I have a question about this though. So look at that aorta. I mean, it's huge, right?
That's a good point.
How do you know that you've got the cannula into the correct lumen when you do this with an aneurysm like that?
Oh, if it's just an aneurysm, it's fine. It's dissections that you have difficulty with.
Okay.
So aneurysms is not an issue. And again, I typically ask you what the pressures are too.
Sure.
On the aortic line. So that's kind of basic. But dissections, yes, that is an issue. And that is, I know Manny does more, Dr. Maniscalco does more of those. Mm-hmm. And that is more of a concern for him. But also on TEE, I think, and also epi-aortic ultrasound, I think that's very important in a dissection to use. You can.
So you're not in the false lumen. So
you can pretty well identify if you're going to find a spot where you're going to pop right into the false lumen or pop right into the true lumen. I think that those board questions, especially the oral board questions, how do you recognize this, et cetera? I mean, because you get asked that. Mm-hmm. Epi-aortic ultrasound eliminates that. And in a straightforward aneurysm, it's not an issue.
Okay.
And typically I do, because I don't do a lot of, or any really, arch replacement, because that's just not my deal.
So look, you see the venous.
I cannulate the arch so I can get as far up on the anometer as I can with the graft. Because typically the ones I select pre-op are just strictly ascending only. I don't do any arch work.
So now look, you put the venous line in. You've got the venous line in. So let's
you see where my aortic cannula is? It's pretty high up there.
Okay, that was the aortic cannula. Okay, that. Okay.
Yeah.
Now, Shit.
That's the aorta.
That's bad. That's bad. I thought that was the venous cannula. What's
See, this is great for you,
got-
Joe. During education. Oh my goodness.
I got lights in my eyes.
Okay, all right.
Good Lord have mercy.
I'll give you
okay.
that.
That's what they all
Hey,
say.
David, you got to edit that out. Okay, later on. Don't leave that up there in perpetuity. Okay.
You can slide us a copy of that though, so we have it.
Dude, that's a five-syllable word, bro. Perpetuity.
Perpetuity. Yeah, you're right. I had to use my fingers to
I'm watching
count.
the video and just count off of my fingers here. So I was like,
So did you want to see something more on cannulation?
No, I
or
want you to
straight
do.
on
No, I want you to.
Okay, we have so much. Let's
keep
go.
going,
Let's go to going on.
Let's go to
because that
20
is some neat
more to
stuff.
23 minutes and 50 seconds. And that's when we initiate bypass.
Yeah, we're not going to make the audience suffer through 23
Oh,
minutes.
this case was hours.
thanks, Patrick.
Yeah, but I mean, it was 2 cases. It was 2
It
cases.
really was 2 cases.
Yeah.
So
And I tell you, we did try to get the film of the TEE when we were making the decision to go back and put the valve in.
yeah,
And I couldn't get it.
Yeah, but it was pretty obvious. It wasn't.
Here, watch, Patrick. You're going on pump.
Yeah, I'm not the perfusionist here. But,
Okay, look at the heart getting smaller, and look over on the right. You'll see the pressure starting to drop down, or should become continuous.
Well, the aorta's not thumping either. I mean,
Right.
It's
And you see the reservoirs going up. You can see the venous blood and the color difference. Look at all, and there's flow right there at 4.5. And your pressure monitor. You want to go over some of that stuff, Patrick? All your different pressures that you're looking at, what that middle module is showing? Here,
sure.
let's
I mean,
see.
it's not all. We haven't given
Let's see.
cardioplegia or
Here,
anything.
look,
so-
this is working. Here, hand them that. Don't click anything, though. You get in a lot of trouble. Magic will come over
so
there.
I'm fixing. I guess the.
Look,
is
he's
it
turning
venous
on the.
cannula or
Yes.
Yeah, so,
and
well-
see how this happens? You're focused on that. But look, Patrick's tapping buttons. He's actually doing something that's important.
Yeah, no.
But you see what I'm saying? And he just made an
He's trying to
adjustment.
take care of all that air sucking in there.
And then look, he's turning, messing with the
Because I think
flow.
it's the venous cannula, not the aortic. So
At 24, and this is not me doing the pump here. This is another perfusionist. This
Okay.
is Mike.
Okay. Okay.
I was there because we were filming it. But anyway, at 24:30, I have a question for you because it looks like we're on pump, and then you're repairing what might be a leak around that aortic cannula.
that's the venous cannula there.
Yeah, that's
So
the
too.
Venus.
No. Well, I know, but where are we on this? Are we at 24:50? 24 minutes? I'm sorry.
25, 30.
Oh,
Yeah, so you're sucking a bunch of air.
no, I know, but this is actually. Well, it looked like to me like. I guess we don't know the difference. It looked like the aortic cannula.
No, we do.
It
There
looked like
you
you
go. I
were
mean,
fixing
it's-
a hole near the aorta, and I was thinking, why not do that before we go on bypass?
Man, I should have looked at
Venous
this with you.
cannula.
Well, what happened?
It was
okay,
the
so
aorta.
let me just say, this is an elderly female. Atria are typically pretty fragile, and then when I pulled or moved the venous cannula inferiorly toward the feet, that little hole opened up,
Okay.
and so you start to suck a bunch of air.
Yeah.
Something you can manage with vacuum, but
Yeah.
it's just I don't like to worry about that when I'm done. When I'm done with the case, when I'm finished with the case, if I've got another purse string stitch in, it's a lot easier to put in here. I just tie it and I don't have to fix it when the heart's full, you're off pump. And some guys just like to fix holes when their heart's bleeding. I just typically like to fix everything before I'm off pump. So that's what that was. I just
Okay.
put another Ramel around it.
All right.
That makes sense.
So we've got what I believe is placement of the retrograde cannula at 28 minutes even. If you can get us there, that'd be great. And if I'm wrong on that, then but that is what that is going to be.
Yeah, that's going to be the retrograde.
retrograde. Okay. How do you know when that's in? I know everybody's always feeling around down there and trying to figure it out.
Man, I watched David Ott put in so many of these, and it was typical on aortas because he didn't really use it on a lot of hearts. And just the way he put his hand in there, and when I was there, they were like, "Okay, you're going to learn how to do heart surgery by just watching the sheer volume of cases." I'm thinking to myself, really? I got to get my hands dirty, etc. I can tell you the first time I did a mitral valve, because they typically didn't let you do mitral valves, was he was in another room, and I asked if I could just keep going. He's like, sure. I'd seen probably like 100 with him.
Yeah.
And it's just like you'd seen so many, you're doing them, and next thing you know, he shows up and you got everything ready for him. Okay, putting in a retrograde, it's more knowing your anatomy, but watching how these guys did it. And if you've noticed when I put it in, I rarely have an issue putting a retrograde in.
I know.
It's knowing your anatomy. It's knowing the volume is big because you're draining the coronary sinus, right? You need to have that orifice open. In this heart, I put a little bit of volume in. You can see they're ejecting, okay? And I get my 5th and 4th digit on either side of the cava on my right hand.
Yeah.
And I lift the heart with my 4th, 3rd, 4th, 3rd, 2nd, 1st digit, and lift it up, and it just slides right in. The key to it is not to have your coronary sinus cannula so curved. Everybody puts this big bend in it.
Mm-hmm.
You need to have it barely a bend in it at all, because it'll follow the coronary sinus. If you have too big of a bend, you're going to miss it. It's going to go into the ventricle or the atrium. The atrium.
Okay.
That's where everybody makes a mistake. I'm convinced is they make it too much of a bend in it, because they all have a malleable wire in it typically.
And for those people that are watching this that are in the operating room, we all know what you're talking about.
These guys.
If anybody's watching that has no clue, they don't even know what a coronary
Dude, I
sinus
tell you,
catheter looks
there's so many surgeons that don't have a clue on doing that.
Mm-hmm.
I'm not, by no means am I Denton Cooley. Okay. I mean, greatest surgeon ever lived. But it's never been an issue me putting in. And I've watched tons of surgeons put it in and they struggle putting a retrograde in. It's
No one would ever argue that
they
Dr.
put
Cooley is the
too
best.
big of a bend in it, and they don't know the anatomy, and they don't typically fill the heart up. I don't like to put retrograde in with the heart on bypass, but you can see we're already on because of some issue.
Mm-hmm.
And so then I'll typically clamp the line or tell you to fill the heart up a little bit to give me some volume.
Mm-hmm.
Okay.
And
You were
that's-
about to put the clamp on here, and we can pull that back up. You're feeling around. I think you're feeling to find out how deep that aorta goes or something just before you put the clamp
I'm
on.
making sure that I got, sometimes there's adhesions around there, and you want to make sure you get it all the way across, obviously.
So,
And I'm also kind of going on to the underside of the arch.
So watch this. So you're going to turn the flow down. Watch the flow come down.
or
It's down.
off,
See that?
pretty much.
It's
And I'm
off
squeezing
pump.
my fingers. I'm trying to get as much.
Look at the blood pressure drop. You're going as deep as you can, and we're helping that by lowering the pressure.
right
Get
on
on
the
fight.
cannula because I'm on the arch and
Now look, he came back up on the flow. Came back up on the flow, and
Nice
look
and
at the pressure
pleased.
come
Here we
back
go.
up.
You have cardioplegia
There's the
rolling.
ice. You saw the reservoir volume. That is so cool, Patrick.
so look at the STs. Wham.
That's not working anymore.
Not working.
No, that's all right.
Okay.
There it is.
Yeah, there it is, right there.
There it is.
Because you can watch these numbers down here. This is the let's see. I can't. It's kind of far away from me, but I think this one. This is the arterial pressure, and then down here is the where's the cardioplegia pressure at? Right
You're
there.
on it. Yeah, it's right above
Yeah,
that.
right there. So those are the two pressures we really want to focus on. Here, oh, I see. Here and here.
And so the heart's still kind of moving around. We can see it on the EKG. But we
I don't have a
we
root.
see
The
it.
root
So
vent's
look at
not
this.
on yet
Here.
because we're still giving pleats. Look, so,
Right.
so look. See, I've never seen this
Right.
before.
Yeah, and the antegrade.
Cardioplegia's still going. Right
Yes,
here.
look at it.
Root
Here's
vent's
the
not on
pumps.
yet because you don't want that on.
Root vent
Sucker's
is not on,
obviously.
right?
LV vent. I use an
And look
LV
at the
vent
heart stop.
directly to the root.
And look at your aorta, how puffed up it is.
Yeah.
Because look at down here, it's your pressure. What's that say? I can't see
160, I
it.
think.
160?
145 maybe.
155? Yeah. So the pressure in the root
147.
is 150 in the line, but that probably translates to about an 80, probably in the actual vessel itself.
Yeah, I don't know.
That's a line pressure, not a
We're under retrograde.
vessel pressure. Yep.
So you see the root vent come on, and that we should see the aorta kind of.
And
Relax
watch right
now.
here,
I'll
you'll
switch
see
it up
this
there.
fill with blood.
And I switch it up top to retrograde.
Correct. So what? You'll see this filled with blood here. Sure. Can you see it now?
And I tell Patrick to put an LV vent on, although I just have it in the well right now because the aorta's not.
Here it is, right here, the root vent. Yeah, here. So you see it's full of blood. There it is.
Because I don't put a superior pulmonary vein vent in. It goes directly to the root.
Gotcha.
And that's another David Ott thing. His philosophy, I think it was kind of unsaid, was the more holes you put in the heart,
The more holes you
places-
gotta close.
The more holes you got to close, and the more
You're gonna
likely you are to bleed.
That's right.
And he always just stuck it through the root. So you kind of get eye blind to when you're first doing it on your own, you kind of get, you're kind of frazzled by this root vent in your way, taking a valve out, putting stitches in.
Yeah.
And then after a while, you've done so many, you become blind to it. It's really kind of, it's like, smelling sweaty feet all day long.
Something else.
You finally get used to it. And when you're in the locker room,
Yeah.
So something
Kinda
I
gross,
wanna-
but,
it
you know.
is. That's a good
But
analogy.
you become eye blind.
Yeah, so let me point out, you notice how much slower this is turning now. We're giving retrograde versus the antegrade. If you looked at it when it was doing antegrade, it was moving much faster than this.
And look at the aorta is completely
And
collapsed. now,
Look
too.
at that. Look at that. Yeah, look at that. That is incredible.
And I typically want you to stop sucking on it when I cut it open.
And actually, look, he just turned the root vent off because you're going to want to open it.
Yeah, he's about to at 35:30 is when you open the aorta, but then at 43 minutes and 10 seconds is the greatest picture of the coronary osteums. It's really cool.
Let's watch this.
And I think we're giving retrograde plegia or something at that time. You can see it coming out.
So I'm trying to get a little more room on the root here to identify the coronaries.
And while you're
this
doing
is what
that,
you're doing if you do a bend tall. But I wasn't planning on it, but I wanted to get as far down as I could and preserve the coronaries.
and what I want to show is, look, you're doing this. Look at Mike. You're doing that. Mike is actually doing something. And Shelly, who's not pictured, is leaning over, looking at where you are, trying to anticipate your next move. And so it really is a symphony. It really is, if you think about it. This is it's a symphony that's actually occurring. Patrick, I think this is just I am in love with all of this imagery. I really am.
Yeah, well, my hope is that we'll also bring this to, I'd like to give it to some perfusion schools. And let
Yes.
them, look this over.
That's a great idea.
So they're at about 11 o'clock coming into the field is my LV vent. It's on, but it's not in there yet. But I did have it in the well, just as an extra sucker. Again, you don't have to. And earlier I was talking about how great I am at putting in the retrograde coronary sinus catheter. I'm terrible at putting in a superior pulmonary vein vent. I can't get it through the mitral valve.
Yeah.
So for me, it was, I did this, so I do this.
You just basically take a drop sucker and just a weighted sucker.
If it's a really big
wiggly, whatever you want to
If
call
it's a really
it.
big one, you can put a wiggly in, but otherwise I use a 10 or 12 French with a malleable wire in it, which, as you well know, took a while to get. Super handy. You can move it to different places. And a tribute to Dr. Safi, I don't know if you can see it in here. I'm sure you will at some point. He always used a coolie scissor for retraction from the assistant. And so
Really?
I've done that to this day as
Wow.
well. It's got a nice curve to it, so it's right under the aortotomy rather, and gives you a nice little lift, so you can cut the valve out, put the stitches in, etc. You can slide it around.
Here it goes. Look, here it goes. You're getting ready to cut it. There you go. You're in it. And look, he stuck the sucker in there. He's probably going to say, turn the sucker up. Well, let's watch, see if Mike does it. That's right down here.
I think Mike's
That was
doing
going fast enough.
Yeah, I think Mike's doing a great job. So I don't think
You'd have had to tell me to turn it up. Mine have been going slower.
So that, again, is the LV vent that's just sticking out in the middle of the field, that little piece of plastic. I haven't utilized it yet.
Right, this right here. Right.
The antegrade's coming out,
Right
so we
there.
don't need that anymore.
Right.
Yeah, the LV vent goes right through that valve at 35 minutes and 30
And we
seconds.
imagine that all of this stuff, all of these things, when you're putting stitches in and you're having to move them like when you do the valve, and I think we'll see it, they can get hung up on that stuff.
I mean, there's enough stuff in there. I try to limit the number of, and this is Tony after she's put on the antegrade. She's super strong. I have to use a hemostat to get it off. But
You knew that the scrub nurse was Tony just by that?
because yeah.
Okay.
Was she the scrub?
Yeah.
Yeah, of course.
No, I just don't know how you knew because of how tight
if
the
I
cardioplegia
can't unscrew the antegrade
It's Tony.
from your line, it's typically Tony.
That's funny.
Now, this, what you see here, this should be a complete straight line, but this is artifact.
Yeah, this isn't. the
This
heart.
is
Trust
not.
me, I would be screaming.
Right. The heart you can see is not moving at all. I mean, here's the down here. It is not moving. And Mike's watching his level here, his pressures.
Right. So basically, I'm going to make a longitudinal aortotomy, and then I'm going to make some cuffs right here, approximately distally. I'm digging down toward the left main right here to make sure we don't get too close to the left main because I want to make a nice sinotubular junction. Now I'm going more toward the head and toward the aortic cannula. I get pretty close to the aortic cannula. There's usually, if it's a normal aorta, right before the arch, a nice cuff inside there, transition zone. And on this one, it's pretty straightforward that it was there. This is not a huge aneurysm. It's about almost 6, but it's a pretty small lady. And her disease process was AI. So that's really all she had.
There goes our
It was
vent.
aortic insufficiency,
Correct.
AI.
There's the vent. It just went through the aortic
Yeah,
valve.
we just saw you drop it in.
So the valve's got some little bit of sclerosis with it. You can see that on the left coronary cusp there at about 11 o'clock. Again, I'm going to leave that if the valve's competent because it's 78 years old or however she is. She's in her late 70s. I was going to leave it. But her valve, when I looked at it, was pretty asymmetric, which I think led to her inability to fix her AI, or at least for me to do it. Tyrone David probably could have done it, but
So now you just took the drop.
I gave it a
sucker out.
shot, and
There it goes again. And to see it fill with blood. You see it flash.
so that's
when you
my
put it in.
LV vent. I don't, like I said, you could go through the superior pulmonary vein. And at first it's a little bit disturbing. It seems to be in the way, but you can put stitches in. You can use your Ramel tourniquets to hold it in place in other places. This is, there's a lot of ways you can get it out of your way to do the surgery, especially in an aneurysm. It's pretty easy to get it out of there and ignore it because the annulus is pretty big typically.
So at 43:10, if we can go up there, I think we're real close to that. But at 43 minutes 10 seconds, we're going to give retrograde cardioplegia, and you can see it coming out of the coronary ostia. Okay, so
Oh, look at the
On the
leaf.
bottom.
Now I'm looking at the leaflets with the
Yeah.
Acepta, the bulb syringe. I'm trying to get an idea of if I can fix this or if I just need to chop it out. I'm really trying to talk myself into leaving this alone or maybe tighten up the commissures or something to save this valve. And right there at 6 o'clock where the Acepta is going in, you can see the right coronary ostium. It's huge.
Yeah, right here.
Yeah.
Right. Let's see, where is this thing?
There's
There it is. Right there, right
Huge. So you can see the
there.
blood drifting in. I think this one, blood came through the right coronary through the whole case for some reason.
oh yeah,
Even though the heart was stopped and flaccid, but anyway.
That is a really cool view of the right corner. And you said we have an even better view, right?
no,
Or-
that's it. That's it.
That was it?
That's it. And well, we have more, but that was the best picture of the right coronary. And we're just about to give cardioplegia now, retrograde.
Typically, the problem with retrograde, as we all know, is do you protect the right heart? Another thing I took from Dr. Safi was antegrade osteal cardioplegia.
Oh, here we go. Here
Mike's
comes our
turning it off. Here's the
cardioplegia
retrograde
going
to
in.
watch. Look at that. Look at
And
that.
I'm giving so
Dude, do you see that?
Oh no, he's
that's-
giving it.
Oh, yeah, that's antegrade. Okay, you're
And
giving
so
it
on-
through the.
a straightforward aortic valve, like in a replacement, I'll give at least one shot through the right and left main. It's a little bit time consuming, but I've found that the right heart really comes back with at least one shot during one of these. Typically, my cross clamp for a traditional aortic valve is less than an hour. Anywhere from 38 to 52 minutes is kind of my average. I know it doesn't sound like it sounds specific, but it's really not.
Yeah, because if you're giving antegrade cardioplegia on a patient with aortic insufficiency, a lot of that cardioplegia
It's
is
going
not
waste.
going down the
Correct.
coronaries. It's going directly into the LV, the left
Right.
ventricle.
And this shot down there really, I think, helps a lot.
And there you go to the left.
Because retrograde just does not work as well, especially in your sicker, thicker ventricle patients. Now, Del Nido is something I'm interested in as far as something like this.
Yeah, we did a
goes,
session on Del Nido cardioplegia.
for my minimally invasive stuff.
Yes.
So we'll talk
Well-
about that.
Yeah, but you don't need it.
For the aortics?
Oh, for the aortics you do, yes.
Not the mitrals.
Not for the mitrals. Yeah, that's the hyperkalemia technique.
yeah.
So why don't we move right on up to 56 minutes and 35 seconds? This is the retrograde that I want everybody to see coming out. through the coronary ostia. So that's going to go in here in just a minute. There we go.
Okay, sucker's up, LV vent's up. Please just going slow because it's retrograde. If you look in the bottom right corner, yeah. So
Right here.
And we
look
can
at
see the
right
pressure
here.
on the
Yep.
retrograde.
There's that. Now let's watch. I think he wants to see something. Oh, look at okay, that's just there's the level right there. And up in here, you want to see this thing's horrible.
I remember this being really dark blood coming out. Here.
And that's the thing. It passes through, oxygenated, and makes passes through several inches of heart and comes out dark. It's pretty impressive.
Comes out venous.
Yeah.
Comes out.
And that's a real good sign that O2 has been extracted.
Yep. Amongst other
Because that's
things.
what you look for, right? Exactly. The potassium and everything else.
There it is. It's much. Now you see it's darker. Look, I'm washing a little bit there, but I'm looking.
Yeah, diluting it, but he'll clear that out.
So watch. So if you look at this valve, I mean, see how asymmetric it is from a surgeon's standpoint. It's almost the right coronary cusp is almost 50% of the circumference.
Yes.
Look at that, because it almost goes straight across, right?
Yes.
And then the left and the non-coronary are like a quarter apiece, a little bit more probably. So that's why in addition to their aneurysm, it failed.
Gotcha.
So it was a fairly the leaflets themselves, the quality was pretty good, but
They just wouldn't
symmetry,
coapt.
well, the symmetry was wrong. There's one leaflet that's super long, and the other ones were
Short.
for lack of a better, relatively short.
All right, so we've seen that. We can go up to 1 minute, 17 seconds, and 1 minute, 1 hour, 17 minutes, and 45 seconds.
So here I put some commissural sutures in, try to tighten things up, repair it. Now we're doing the proximal anastomosis because I want to look down the tube here and.
That's exactly what I wanted everybody to see was
Yeah,
the way
now-
you're filling it up. To see it.
So we'll do this running suture all the way around, recreate the sinotubular junction to tighten it up and hopefully coax those leaflets together. To test that, there's really no other way to test it. You can't do it under pressure except when they're off pump. But we'll do it with asepto and saline, and it looks pretty good. But bottom line, at the end of the day, when we come off, it doesn't look that good on echo. And
Right.
So we never reversed and went back on and just I went through the graft itself and just replaced it.
So now I think this is going to be interesting for Shelley because Shelley sees this part. She can easily see what you're doing here. But I think where it's tough for us and tough for any clinician that's in the room, besides you and maybe your first assistant, will be what Patrick wants to show you. So you want to speed up to that point, that part?
Well, yeah, we should be. Okay, 1 minute,
gonna show
1 hour,
this.
19 minutes, and 45 seconds. If you go to there, that's where we're filling the.
Because this is the part that I think that we don't see unless somebody's looking over your shoulder or wanting to see.
Well, I think I had everybody
there.
look at this point.
Yeah, probably you do, but a lot of people do not, and a lot of
I
people.
usually like to show people what we're dealing with.
Yes.
Because most people don't, like especially an assistant on a mitral valve, they never see what they're assisting
Right.
on.
So, Shelley, how many times have you ever seen that view?
Well, since I scrub, I see it.
But when you're
No,
not
watch
assisting,
this.
if you're in the
Watch
back,
this, though.
yeah, I'm talking about that
Down
view,
the
right
hole here.
down the hole.
Yeah.
I mean, I would say only two people in the room, generally speaking, are going to have that view,
Yeah.
unless they have cameras and
Where-
somebody's focusing it.
Where is the LV vent right now? You
It's
took
not
it
in
out?
Took it out.
Okay, all right.
So I washed the ventricle out, try to get as much blood out as possible so I could see the leaflets, and then started squirting saline in to get a clear view of it. So again, I want to test it again. I'm going to suck all the blood out.
For our perfusion colleagues, usually we don't like you to use the pump sucker for that.
I know,
Okay.
but I don't care at this point.
So when my perfusion colleagues out there, let's see.
Can I ask why?
It dilutes your it dilutes your blood.
Okay.
Volume, basically, you're adding volume and you don't need to add it.
Just because you're irrigating?
Well, it's a pretty good shot there.
Have you got some YouTube chat questions, Joe, coming through?
No.
Oh, okay.
So I'm feeling okay, but my backup plan is, it's pretty simple. I'm not concerned about it. It's just simply replace the thing.
Yeah.
So there's a great view. So it looks like it's going to co-op pretty well there.
All right. So let me see. What we can do is we can go to 1 hour, 27 minutes even.
Look at that. Look at that.
I'm gonna call you back.
I know there's some really good.
That is
Great
so
shots.
cool.
Yeah, 1 hour and 27 minutes. What we got to show you here is there's the artifact, which we noticed.
Oh, yes.
So you look here, look. So the salion's staying in there.
Oh, it looked like it was going to work.
It looks like it's going to work.
Look.
Yeah.
Yep.
So once I got the leaflets to do what I wanted to do, it looks pretty reasonable. And the sinuses themselves were not aneurysmal, so that's why I didn't do a complete Bental at the end of this.
So what Mike is doing here is he's got some lube. He's putting it around the raceway on the sucker. And you can see when he turns the sucker off,
Now
that
let's
the EKG is flat.
Wait, go back because you see. Let's do this. Go back just a few seconds. Okay, right here. Okay, look at the artifact right here. Okay, it almost looks like the heart's beating, and that can be pretty confusing if you're thinking there's electrical activity.
Well, if the surgeon's not yelling at you, it's probably not.
Right, exactly. That's true. But still, nevertheless, some surgeons you'd be surprised. Now watch him do the loop. So you see the artifact. Now let's watch him do it. So they see that.
I told you this works.
No, wait till you see it work. Wait till you see this. No, this is good stuff. Do we have the lube in the tube? Where'd it go?
Oh, it's we got to go to 1 hour 27 minutes,
So you saw the artifact.
and then just here in a minute he's going to stop the. When he stops that sucker, the artifact goes away. So we know
Okay,
that's
so
the
you
problem.
see, he opened the pump head. Look, see the artect's gone?
Interesting. Oh,
So now look
at that.
now look, now this is Mike doing basically a prostate exam on the pump. Now he turns it back on, and look, it's gone. But watch this. Watch the consequence of lubing the tube. Watch this pump head right here. Watch this. Keep an eye on it. Don't take your eyes off of it. He's going to put some more. He's going to lube the tube some more. Mike wasn't happy. He didn't get deep enough, so he needed to put some more lube. Now let's watch. Keep an eye on this pump head.
You know what he's doing, dude? I'll tell you what's funny about this.
Did you see it?
Yeah.
Did you see it? Did you see what happened? Go back just about 5 seconds. Go back a little teeny bit. That's okay. Just let it run. Let it run. Don't go back. Don't go back. Don't go back. Don't go back. Just keep an eye on the pump head. Keep an eye on the pump head. It jams.
Yeah, the tubing starts creeping through there.
Yeah, go ahead and let it run.
Because of the lube and all that.
He turned it off. No, now he's taking the lube out. Okay, Mike, you lubed the tube, and that was too much lube. Okay,
But now it's perfect.
so can you go back 20 seconds and just
I'll tell
play?
you what the most impressive part of that was. I didn't even know that was going on.
Right.
I mean, he did it when I was using the self-safer sucker in there.
Yes.
Did you notice that?
Yes. Well, no, because this pump sucker stops working and you switch to it. You just go back like 20 seconds. Now watch that pump head. You'll see it bounce up, and when it jams. No, see, you went back too far. Just like 10 seconds, 1 minute, 17 seconds, or whatever, 1 hour, whatever it was.
Lube is good. That's all.
And hold on,
We can move on if you like.
No, I really want them to see this. I really want you to see this. This is classic. This is classic Mike Brown.
Troubleshooting.
Yeah. Okay. That's more than guys. Let me ask you: Where was the lube in the tube?
The first time is at 1 hour 27 minutes.
So go to 1 hour 26 minutes.
Well, then we have a whole minute to wait for till he does.
Okay, but he can't do seconds. I mean, you're asking him to do too much.
Should we? You want to take a commercial break and get back to this?
No. Okay. I think this is the first lube event. I just want to watch it again, all right? Can I just be entertained? Now watch it. Just watch it.
It works.
Yeah, no, it does work, but the consequences.
Oh, come on.
Watch the tube. Watch the pump. See, you're trying to use the
You
pump
go,
sucker.
Mike.
That's the pump
You go,
sucker.
Mike.
That's the pump sucker in your hand, okay? The pump sucker.
No, that's the
That's the pump
cell
sucker.
saver sucker with the
No,
light.
that's
The one on the at 3 o'clock is the lighted
is the-
cell saver sucker.
Okay.
It's different than a regular.
All right.
It's lighted
Just watch it jam. Watch it
by
jam.
Invuity.
Watch it. There it goes. It just jammed. I saw the pump head pop up. And he's like, oh, shoot. Now what am I going to do? Oh, let me turn it backwards.
I'm using the pump sucker.
Let me
for the
try to get some of
tractor.
that out.
I guarantee you, I did not.
Oh
even
yeah, see, you're
notice.
trying to use it. It's not working.
I told you.
I didn't even notice.
Now it's, see, you just tried to
Mike,
use
I
it.
didn't even notice.
All right, go
I
on.
didn't
Let's,
notice.
okay,
Good
so
job, Mike.
so do we want to? So what do we want to do? Any discussion? What do we want to do?
Well, we
Keep
can
going
we
down
can
a
stop
couple
here
more
if you
things?
want, and there's a couple more events to talk about. And
Let's talk about some more events. Go to
All right.
your next
So the
one.
next
There's
one-
Mike wiping the gel. There you go.
That's perfect.
That's kind of like when you go get your prostate
Yeah.
checked. They hand you a little piece of wax paper. Like, what good is that going to do? Oh,
It's 7 o'clock.
yeah, we know.
Let's take a look.
No, we're going to go through a couple more things first.
okay,
Just a couple more things.
go to 1 hour and 42 minutes. And what we're going to see here is we're giving retrograde cardioplegia to fill the conduit, I believe, to get to de-air. So we should see that kind of fill up here in a minute.
Man, I am. Look at that.
You are. I know. This
I
was
didn't even realize that.
this was the shortest aortic root replacement, followed by valve
Reopening.
conduit that I've ever seen in my life. You know, you beat Cooley's time.
Of whatever. I didn't use a running suture for my valve. I don't know how you ever did that. That's amazing.
All right,
Okay,
so we're
so-
giving retrograde now.
And to check his
And
anastomosis.
we should see the conduit fill up.
Yep. So let's watch that. So you want to watch this?
So I just stick the LV vent. That's the other thing about having the LV vent through the root. You can stick it wherever you want. When the
So now he's
aorta's
running this
closed.
pump head right here, and
Just-
watch that fill up right here.
I'm going to put the vent in, antegrade, retrograde vent now.
Yep.
So you should start seeing this. So you now of course the pressure you're going to get from that's going to be fairly slim. It's just helping you put the suture in. You're not testing your
Exactly. No,
anastomosis.
I'm not testing it with that. Right. I'm de-airing. I'm also filling it up so I don't back wall it. Not that that's an issue. But also just time to get pleats.
Mhm.
You
And
know.
when you say back wall, you got to remember, depending on who's watching, a surgeon's
Yeah.
going to understand that. Maybe somebody as old as me might understand that, but most people are
But
not going to get
snagging
that.
the other side of the conduit where it's going to pinch it off, and that's just bad technique from a surgeon standpoint.
Mhm. That's like having a garden hose with a clamp over it.
Correct. Yeah.
Part of it.
Yeah.
So you're about to stick the antegrade needle in through the
And
conduit.
we had done this previously through the aneurysm, took it out because we resected the aneurysm.
I have a question for you.
Mhm.
Does that Dacron, is it Dacron?
It is.
It's Dacron. Does that act like tissue? Because you put a normal purse string around it. Does it act like tissue when you close that purse string up in terms of hemostasis?
Surprisingly, yeah, but it's because this is Hemoshield Platinum. I'm not a huge fan of because the edges fray. If you really look closely, I've everted the edges proximally for
Right
sure,
here, I can kind of see it.
where
I know
I
what you're
folded
talking
it back
about.
on itself.
Right here.
And so you get a double wall of the graft itself sewn to the aorta, it typically leaks less.
Mm-hmm.
The edges fray a whole lot. If you do bypass grafts off of it, you'll typically use an eye burner, a ophthalmic burner, to like you would if you're tying a nylon rope. You cut it, you burn it with a lighter at the end, so it keeps it from unraveling.
Yeah.
That's the problem with HemoShield Platinum. HemoShield Gold really doesn't have that problem, but for whatever reason, maybe I.
So now you had a hard time getting that in.
Well, it's tough. Yeah,
It's not enough pressure.
It's not enough pressure. So if you see, I'm lifting up both ends of that horizontal mattress suture to get some purchase and some resistance. So I use an 11 blade.
11 blade, yeah, that always
Because
makes
that
a
needle
hole.
didn't work very well, but just little technical things here. This is a Ramel with pledgets, so I can just tie it at the end when I'm done.
At this point, we're not even rewarming yet, are we? I can see the
Temperature's
the
right here,
temperature down below
28.4. Look, right here, 28.4 and 29.5 degrees. That's centigrade for anybody that's non.
Yeah. So let me see here. What could we do next? You know what we should do? We probably should take a break right now because
Okay.
all that's left is we're going to take the clamp off, and then we're going to basically do this surgery again by replacing the valve. And that could
Okay.
be the second half of our show.
Okay, that's fine. That'll be
Okay.
good.
All right.
All right. So why don't we do that? We'll take a break. And Dr. Mettauer had to take a quick telephone call. He's still working. And why don't you guys take 5 minutes or so, use the restroom, fill up your perf web cups that we sent you in case you need to get one. Make sure you don't leave without one. Okay, this is a party gift. And we got to order some more. And we'll be back in about 5 minutes. And welcome back to the show. Hope everybody got a good break. Okay, so we're going to open the phone lines. So we'll put that notification up that you can call in. And I've got the phone here in case that was you trying to call earlier and I couldn't answer at that time. You got to wait till we say open the phone lines. We still have the YouTube chat on. So if anybody wants to do that. Let's continue with Patrick. Patrick?
So we're going to pick this surgery up where the cross clamp is about to come off for the first time on this case. And this is Dr. Mettauer's own personal way that he came up with on how to de-air. So that's at 1 hour, 46 minutes. If you can roll, and we can kind of talk about how we do this. It involves antegrade and retrograde and all kinds of fun
That's
stuff.
my own thing. But it does serve a purpose.
No, it seems to work. So, but you invented this.
So look,
I'm sure there's a lot of guys that do this.
look, Mike's running it up.
I'm trying to de-air. I'm trying to test the anastomoses, de-air. Mainly it's the de-air and test the anastomosis, but I really want to get all the air out. So
Well, you must be getting retrograde. You're probably giving retrograde. there
retrograde
to try
right
to
now.
fill
I'm
that
waiting for it to
crack.
come up through the.
Okay.
There
it goes.
So now it comes up.
And you're getting some air out there probably.
Mm-hmm. So this is going to be the antegrade part of it, and the vent's already hooked up. And then I'm switching back and forth up there, communicating that, of course. My LV vents.
Oh, you always tell us everything you're doing. There's no question about that.
I do. You know I do. I tell you.
I think I would.
I'm the best
I'm
one.
going to agree with you on that because during this time you are communicating because there's a lot of switching going on. There's
That's because he knew he was on camera.
Uh-huh. Right. No, because it's a little weird, a little different.
And
All right,
then-
so we're going antegrade now. I think. Yep.
Yes, because you can see it's distended.
See the root right here is just right. There it is right there, distended.
And I'm poking it to see how tight it is. What's your pressure, Patrick? What's your pressure? What's your pressure?
And our pressure's right here. What's it
Yeah, we
say?
know the
I
pressure.
usually get it up to about,
It says,
or at least the measured pressure about 180.
so the systemic pressure. So right there, it's 74. Say I can't get this.
Okay, now
mouth
we're going to
work
switch
right.
to retrograde again.
Mm-hmm.
I think that's.
And what a lot of people don't also realize is the whole time all
That's
of this
antegrade.
is happening,
Every time
Mike-
I'm doing this, though, it's antegrade, correct?
Yeah.
right? But Mike, this whole case, and I'll bet very few of us have paid attention to this reservoir right here. Keeping this full is critically important to this whole procedure. We can't run that out of blood because if we do, we got a big problem.
Right.
Now your pump flows down. You can see the arterial pump head.
I'll take the clamp
Pressure
off.
drops, clamp comes off. And then I believe we do come off pump, and then that's when you decide to go back on.
Right.
And
So
place it.
essentially, suture line is hemostatic. I really try to fix everything with the heart clamped, or at the very least on pump. It's just a lot easier. Of course, in these aneurysms, the suture lines bleed until you get protamine typically, but from a needle hole standpoint. De-airing a little bit. Heart's filling up. Just trying to decompress it. There we go. Tap it. Good.
And look up here. You can see a little bit of activity is trying to come back.
Right.
But now it's being perfused.
Mm-hmm.
So root vents on.
Oh, you're going
LV
to
vents.
defibrillate it because you got fibrillation.
LV
So
vents
these
on.
are the paddles. Yeah. See the paddles going in. And watch the heart jump. Watch it. Oh, didn't see it. Oh, going to do it again.
Well, I did it again because I gave it a cheap shot.
Okay, let's watch it. Let's watch it. They're charging it. You can't hear it, but it's going
Big, thick heart.
pop. See the pop?
There you go.
We did remove the audio. You asked us, said this is
Yeah,
the
we did
audio.
take-
You're not going to be using that, right? So it's not.
Well,
in
it is
there.
a heart surgery.
And there is a good reason for that, folks. There is a good reason for that. We'll narrate it. Okay, there you go. Look at that. You've reestablished
So-
the rhythm.
Then we'll fill the heart.
And you know what? Let me say you
But
something
look
right
at
now.
the. I mean, you can tell by that EKG. The protection is pretty good.
Yes,
pretty good,
but-
pretty strong.
But see what I see right here? You know what that tells me? You know what that tells me right there? It tells me the same thing it's going to tell you.
Low AI.
We're on full, we're on full bypass.
And you got flow.
And you're seeing
I know,
pulsatility.
Just right, man.
Right.
I know. I got a second plan. It was my first plan, but I told her I told her I would give it a shot.
So we come off bypass at if you can go to 1 hour 55 minutes and 50 seconds. And that's just going to be filling and coming off for the first time.
EKG is looking pretty good though.
Oh, back on pump. Cross
Good job,
pump back
Mike
on.
Brown.
You went too soon. You went too long.
Oh,
See, it says
1 hour. Oh, it should be 1 hour 55 minutes and 50 seconds. That was it?
because
No,
it
well,
says.
it's too far then, I guess.
Well, now it says. See, that said back on pump.
Yeah, we've seen. We haven't really
Well,
seen.
maybe you haven't come off yet. Maybe that was just to go to fill the heart or whatever. But it looks like you're trying to come off right now.
We go back on at 2 hours and 6 minutes.
Okay. So let's
So-
just do this.
I don't know where we are.
Look,
There, we're coming
Mike
off
just
now.
clamped the tube. Look at that. He clamped it right there. You are off pump. Blood pressure is 102 over 6 over. Drop it a little bit.
And if you look here, the pulse pressure is pretty wide for a low. It should be a
Yes,
pretty
right here.
narrow pulse
Yes.
pressure.
Yeah.
I mean, just from that number.
That's another indication of AI because you're not getting a good dichrotic notch.
So why would that valve hold the water when you? I mean, is it just because of the way
It's pressure.
It's just
It's-
more
it's-
pressure. Okay.
Yeah, it's just a lot more pressure.
Mhm.
We have more pressure. It just wasn't gonna.
And maybe to the geometry, where it's squeezing, it's opening, and then
Well,
it has
yeah,
to
I mean,
coapt
it's lots of different things. I mean, because again, the leaflets are very asymmetric. I mean, it was pretty obvious there. You could see that the right coronary leaflet was big,
Yeah,
and
because
the others were like it was like a quarter and a half, and that's just not normal.
Yeah.
So we're going back on.
That's
Yeah,
'cause
we're
they
gonna
went
go
back
on at,
That's because they're going back on.
I
pump.
said, this ain't gonna work.
2 hours and 6
Back
minutes
on pump.
and 20
There we go.
seconds.
I mean, we made a quick decision because it was pretty obvious. I mean, it
Right.
was.
Right.
I mean, it was moderate. It wasn't. She could have survived it and done well and been off pump and probably
But-
done okay.
So
But it's not. We're there to fix her aneurysm mainly. in addition to our valve, but it was the valve was not severe by any means.
Okay,
So
are
there's your
you going to
clamp going
clamp the
back on.
conduit?
No, I'm
Okay.
still above the
All right,
conduit.
okay. So it's a good thing the aortic cannula was up so high.
Well, that's why I put it in the mid arch if I can, because as far up as you put the cannula, it's never far enough. To be honest with you.
Okay.
That's a real good point.
All right. So
That's why I always appreciate the work those aortic guys do, like Caselli and Safi, and I mean that's just big brassman surgery, as far as I'm concerned. And Manny, I mean he does a fair amount of it too, Maniscalco.
Mm-hmm.
So we're arresting the heart again, antegrade cardioplegia. If you can move on to 2 hours, 10 minutes, and 10 seconds.
Again, if you see that the LV vent in the bottom right corner is still rolling, it's at that point it's still just in the well. I use that as an extra sucker in the well when the aorta is closed. I do not go. I just cut the graft open here. This is it's not a calcified valve. Real easy to come out. This is
So you're cutting the valve out here,
cutting leaflets out. Yeah,
Okay.
It's super easy here. So if you look at about 5 o'clock, this is Safi move here. My assistant Denise is retracting the neo-sinotubular junction inside the graft. It's like the perfect curve with the Cooley scissors to expose the annulus, and just all you got to do is slide it around opposite of me, and it just makes for a nice exposure without having to use some fancy retractor or something like that. Neat technique that I learned at my time down at Herman Medical Center.
Do you ever drop a piece of debris down into the ventricle?
Yeah.
So then we just suck it out?
So it happens occasionally, but if it's big enough, you see it. If there's any grainy stuff going in, I usually stop what I'm doing and use a debridement sucker, which is a little more focused suction to scrape all of it off, kind of like a big Fraser, plastic Fraser sucker. One time I had an assistant, Jessica, not Jessica, Jessica, in that little corner where you clamp and the aorta bends at the bottom.
Mm-hmm.
A chunk about the size of a fingernail had slipped down in there, and I didn't see it, but she saw it because she was looking up, which would have been a stroke. Now, I used to use the Emblex filter all the time on all those, and I didn't even really think about it. And the largest piece I ever had was about the size of a thumbnail, which is a big piece, which I had no idea how I lost it in there.
That's a boulder.
But it caught it in the filter. But every time that filter came out, there was always something in it. So I was pretty disappointed when that came off the market. So now I'm obviously much more diligent washing, flushing, suction, debris.
They have a new cannula. You might want to consider it. It's called the CardioGuard.
Mm-hmm.
And how this works, Medtronic.
Yeah.
I believe it's Medtronic. No, it may not. I take that back. It may be a standalone company.
Yeah.
They may, or Medtronic may be looking at them. I don't know. I think it's a standalone company.
Mm-hmm.
But what it does is the perfusion part of it is here, and further distal is a vent, and so it's constantly taking out while you're pumping in, and it's enough to where if there's any debris, because it too can capture particulate contamination as it comes out of the cannula being jetted out, it'll suck it back up, but it doesn't steal enough of your flow that it affects your perfusion.
Yeah.
I think we should at least look at it.
Sure.
So one thing we missed, can you guys go back to 2 hours, 12 minutes? Real quick there, just for a second. This is the sizing of the aortic valve. You went back already? Okay. So you stick the sizer right there. You've got the old valve out.
There it is. Yeah.
21, it said. 21 millimeters.
Yeah, so how do you decide? What are you doing?
Exactly, that's my question.
What are you doing with that thing?
Okay, so there's two ends to the sizer. Does that really say 21 on there?
I thought it did, yeah.
Man, that's a pretty big annulus. So that is the interannular sizer. And there's a plastic cylinder on the bottom, and on top of it is the shape of a normal annulus. So it's got those scalloped edges on it. And the cylinder should go through the annulus, and that ridge, that scalloped ridge, should sit on top of the annulus. If it goes all the way through, then you go with that part of it, the whole thing, because that's a little bit bigger than the cylinder. Then you need to go the next size up, because the cylinder should fit inside into the ventricle, but the scalloped ridge should fit just on top of the annulus. And it has some stretchability to it, especially in this person, because she was not a stenotic. And so you definitely don't want to undersize in this case. Now, the old mantra about do not oversize. If you're in doubt, always undersize one. That's the way I was taught at THI. But I really try to fit it as perfectly as possible, because you don't want to undersize these people, because then you basically have mild stenosis to begin with. And you want a gradient of less than 10, but less than 5 ideally. And the best way to do that is to size it as perfectly as you can.
So when you take the aortic valve out, you're really only taking the leaflets out. You're not digging into the annular structure at all.
No, but you can get into it if there's big chunks of calcium that come out with it. The Cooley scissors, I mean, they're multifunctional, but
that's why they're curved like that,
right? But they don't really cut. I mean, it's hard to explain unless you've seen it used. If you get it in the right plane, it will literally peel the valve out in the correct plane without having to cut it out.
I see.
When you snip and snip and snip is when you get a kind of a jagged edge, and it's not the native annular size. When you get in the right plane and you basically use it to lift and scrape, it leaves the correct size annulus behind. And you don't run the risk of, or you push it away while you're pulling on the leaflet. There's 2 ways to do it. And you don't, I've gotten in the right ventricle a couple of times because it's the thinner part, but you can easily fix that with the stitches to place the valve.
Yeah, but if you get into the mitral, on the other side, I understand it's thicker, but you're in trouble.
Yeah, but that's pretty hard to do.
Pretty hard to do?
Yeah,
okay.
That's a lot harder to do.
So what we have here is a bunch of sewing for a long time, and we could probably go not that long. No, I can tell you exactly how long.
This was a painfully long case.
12
painfully
sutures.
Long.
12 sutures for size 23 and above. 9 sutures for 21 and below. I mean, I know there's guys that put 20 in, but that's the way I was trained, and it works great.
So very low. Well, you probably have a non-existent paravalvular leak rate, because that is like really bad.
It's I can't tell you the last time I've had one.
And that's what I find so interesting, is that if you're, of course, I've been exposed more to TAVR here lately, which I'd really not spent a whole lot of time with. But, it's amazing to me at how when you do a TAVR, if they have a small paravalvular leak, they're okay.
Well,
but if that was a surgical thing, it would freak out.
Well, because there's 2 reasons for that. The TAVR valve has a mechanism for fixing that over time with protamine and healing and scarring. It's the way the bottom of the valve is. Along with the new Intuitive valve by Edwards, basically a valve on a stick, same valve.
Or
it's got that PTFE Dacron on the bottom. It's all fuzzy and everything that promotes a good seal over time. So if you have a perivalvular leak and it's small or tiny, you leave it alone, it's just not going to be there.
Okay. And we got to be nice to one of our sponsors, Levanova. Their Percival valve. They have a similar to the Intuitive
Just
valve.
waiting to hear from them.
Okay, good. So you would try it.
Yeah.
Levanova?
I think it's sutureless, right?
Well, it's not sutureless. You put 3 space sutures in.
And I found that typically, though, it's 4, and at least for the Intuitive, and 2 on the non-commissural, the non-coronary side, because that's where you're going to get your leaks, where the mitral is.
Okay.
If you put 2, ever since I've done that, I've had 0 perivalvular leak.
Good.
So I'll put 4 versus 3.
Good. Patrick, I'm sorry.
That's fine. 2 hours and 27 minutes, if you can get to there.
Oh, my goodness. What a case.
I know. So,
I mean, I don't even think
this
I
is
can.
gonna be
I don't
seating.
think I can. Mike is really a trooper, because I don't think I can run the pump this long.
Yeah.
I don't think I could make it.
I
Does
gave
he
him a
need a
couple
nap?
weeks.
Need your afternoon nap, Grandpa?
Probably do.
I wasn't going to go there, but okay.
That's fine. For those of the audience that didn't hear what my lovely wife just said, she said depends. She doesn't have a mic on, so apparently my partners up here in crime thought that
We're
was
thinking
funny.
it. She just said it.
Yeah, exactly. She's one of those types that says what others are thinking, but shouldn't say. We there?
All right.
But yes.
So we're seating the valve.
Yeah, we're seating the valve now, right?
It's a little different here because I went through the graft. I didn't want to cut through my repair, my anastomosis proximally, but I knew the size of the, and you can really tug on this now because it's graft. It's not the root, right?
Mm-hmm.
It's not the aorta. And it actually went in pretty easily.
And here's the part coming up here in a minute that I wanted to see where that.
We're releasing the strut here for the stick.
The valve on a stick.
They're all valves on a stick. It's just,
How do you release it from the valve? Was there
there's 3 proline sutures,
Okay.
basically proline monofilaments that are attached to it with that little plastic bird cage looking thing on top with the metal handle.
Mhm.
The metal handle screws into that, and then you just cut those and it pulls everything out.
So now this is not going to be core knot, right? What you use?
Oh, yeah.
It's going to be core
I
knot.
use
Okay,
core knot
that's what I
earlier.
had seen on this earlier. So we're going to see that.
Yeah,
That's fast.
This is cool. Yes.
So I will say
There's the
this:
vent
I
going
was the
back
first guy in Houston to use a core knot.
Really?
Oh yeah.
Mhm.
But I didn't use it on the aortic, so I was always kind of scared because I didn't like necessarily the way the clips stood up, kind of proud. I was a little worried about that with the coronaries, the ostia. It took me a long time to actually, there were a lot of people doing it for the aortics before I was, because that took a long time. But mitrals, I mean, my back stopped hurting after I started using it with mitrals.
And for us, for perfusion, it really posed a big problem because if we waited until you told us to warm, like we're at 32 degrees right now. If you look over there on that right panel on the right side, 32.2, with that core knot, and you have 9 sutures there at the core knot, we aren't going to get to 33
Correct.
by the time you're done. But then you still have to close your aorta, so we have a little bit of time.
Right.
And this patient was a small female, is that right?
Yeah.
Smaller female, which buys us time. That's going to speed the process up too. If it's a 300 pounder, that's a real problem.
Yeah, he's a large heat sink.
Right.
So this is our core knot, the tying device, right?
Yep, that's it right there.
Pop
Just
it in
did
there. And
And I'm a little bit anal about putting these in. I like to make sure I definitely see the coronary ostia. I like to see make sure it gets on the right edge, the correct edge of the annulus. Putting it in because you can actually
Man, that's a view,
misplace
though.
it,
God, that's a pretty view.
and then you get a little bit of. Then it's a little loose, and then you get your paravalvular leak. So there's kind of like 2 ridges there of the.
I mean, look at there it goes down, and that's it. Instead of throwing how many knots is it? 8?
Well, if you got a small annulus sticking your I got big hands sticking your big digits down there and tearing the aorta.
Mm-hmm.
it's 8 all the time, 8 knots.
No, 21 and below.
No, 8 knots.
Oh yeah,
to
8
tie.
knots. Oh, when you tie. Oh yeah, at
Yeah,
least.
when you tie, it's
Yeah.
at least 8,
It's at least.
Okay.
and that's to keep that's to lock it.
If it's Tycron, you can do 5. If it's Ethibon, you need to do at least 8 because it slips.
And when you do it that way and have to cut them, that's been found in those Emblex catheters too, is
Yeah.
suture thread.
Thread.
Pieces of the suture.
So if you look at that little spot, I was actually on top of the second row of the cuff, and then I slipped it below.
Go back big.
That's okay. It's not
no.
used up. But the surgeon, you can't, even though it's quick, you don't need to be sloppy with it. I have had this misfire a handful of times, and it's always on like the last or next to last suture. So you got to take everything out and start all over.
And look, that valve is made out of bovine pericardium, right?
Correct.
But isn't it funny how it looks like it's a piece of silicone? Now they do a process to it for
Right.
to help it so it won't develop calcium. And I guess that's why it gives it that looking texture.
You know, I just thought of something. You have to arrange that valve in a way so that it's fairly anatomically correct for its position on the corner.
Oh, absolutely. So
right?
what so you're trying to line up. So if you see the posts, those are your commissures. So at 9 o'clock, where that suture is that I haven't coronated down, that's where your left main is. So you want that because that's the bottom part of your valve, the lowest part of the valve. So you get, when you have diastole, blood tries to go back through the valve, it goes right through the left main at the bottom of that cusp. If you have the left main where that post is at about 11 o'clock, 10:30 o'clock, it can be obstructive. But I honestly think the obstructive parts that come with valves being in the wrong place happen for two reasons. One, you've either folded the sinus in half and pinched it. Okay, even though you have the sutures placed correctly, the valve is not seated correctly. But I think more commonly is that if you have a valve that may be a little too big or you don't have the sutures exactly right, it stretches usually the right coronary sinus to where it fish mouths and makes the right coronary ostia slit. Because, I mean, there's no heart surgeon, when they're putting these in, that puts the suture through the coronary. You see what I'm saying?
Yeah, you got to go around.
But they show as having ischemia or right heart failure or something like that. Oh, it's air or whatever. Throw a graft on it right away. I'm telling you, the times I've done it, they come right off.
Yeah,
It's when you've struggled and you're trying not to do an extra bypass because you don't want to take vein, etc. Then you have trouble recovering them. And sometimes you get away with it, sometimes you don't. But I don't think you're not sewing the coronary shut. I think you just change the anatomy up. Because the other thing is maybe the aorta is not pliable enough. And when you sew it together, you're actually shortening the aorta a little bit, right? A native aorta, I'm not talking about this case per se.
Right.
I think it brings up the right coronary to where the right coronary kinks down because you're stretching it when it sits like this. And then when you put the aorta together, it pulls the ostia up and it's tinted down now. And so it's kinked. I don't think it's they always talk about a technical error. I think it's more of changing the anatomy of the coronaries.
And, and it's so intuitive that you just said that, but I never thought of that before.
I mean, it's not guys putting the suture through the wrong place.
Right. Well,
I honestly think it's you changing the dynamic and the anatomy of the heart.
You say that, but remember when you put that cross clamp on?
Yeah.
I have seen somebody put an aortic cross clamp on, holding the clamp in their right hand. And they were standing on the normal surgeon's side of the table. And then couldn't quite figure out why they putting the aortic cross clamp on, holding it in their right hand, standing on the normal surgeon's side of the table, and applying it, and then not being able to figure out.
So they're giving bleeds to the brain?
So they couldn't
giving bleeds to the
figure out.
brain, right?
They couldn't figure out. They couldn't figure out why they couldn't pick the heart
That
up.
happened to you? You saw that?
Yes, that's happened to me.
Wow.
Yes.
Okay.
I've seen a lot of stuff. Don't ask me who it was.
Someone
It wasn't here in Houston, just for the record.
Somebody had a story, it was one of you two, had a story about the cross clamp being backwards so that it was in the way of the heart.
That's what I was saying. That's what I was talking about.
Oh, my goodness.
That's what I was talking about. They put it on.
So the clamp was over the top
Yeah,
of it.
for him, when he puts the cross clamp on, he has it in his left hand
Yeah.
towards the head. If you're standing on the surgeon's side of the table, it's the right side of the patient, right? So if he's standing here like this and the head's there and the aorta's here and the heart's here, then he's got it in his left hand and he does like that and puts it on. He can't put it in his right hand or he'd have to turn it around like this. So if he has it in his right hand and he does it, the handle of it is right over the heart.
Yeah.
All right. Here I'm blowing some CO2 in here for obvious reasons. And then should be getting ready to close the aortotomy, graftotomy here.
Let me see.
Yep, here we go.
So we have the final conduit sutures are 2 hours and 41 minutes. We have 5 minutes left on the show, so we've got to get through this.
Okay.
We're close.
Okay. We have to have a little bit of discussion. So go ahead. I'm not
can you
going
go
to say
to
anything else.
2 hours and 41 minutes? Okay. So these are the final sutures. Looks like it's sped up. That's pretty fast.
Yeah.
That's just me, Patrick.
Man, that's cool. Cooling speed, did you say?
No.
That's cool.
Let me tell you, Cooley speed does not look like that. Cooley speed is just not stopping. That's how he did it. He was so incredible.
Man, look at that blood pressure, Patrick. What are you doing?
That's not me.
The pressure's on.
It's Mike.
Mike.
I don't. Yeah,
over 71, something.
There's no. That's not right.
It's not pulsatile.
What's wrong?
They were drawing a blood gas or something.
No, they weren't drawing a blood gas.
Dude, it was you had a pulse pressure of like 50. Didn't you see it? It was like 110 over.
Okay. That looks like a lot of Neo. That looks like Neo to me.
Okay.
So the clamp comes off at 2 hours and 44 minutes. And then we'll watch that because we're going to have the deering process again, and then we come off bypass.
Okay, well, the clamp is off. He's starting to, there's movement here. Unless that's his hand.
Deering right there.
There's a
Okay, you're
deering
deering the ventricle. That's what it is. That's just an artifact of you moving the heart around. So you just stab a needle right into the left ventricle.
Yeah.
And I noticed you don't have to suture that.
Okay, so another technical thing: go in, angle it, go another direction, change your angle again, go in. So the hole you create is a zigzag path through the heart, even though it's straight needle. And when you pull it out, all those layers fold over each other.
Oh, really?
If you stick it
pretty cool.
straight in the heart,
Yeah. Then you
it's
gotta-
more likely to bleed.
Huh. Okay. That's it.
That's
Cool.
a good idea.
All right, so we come off pump at
I
2
didn't
hours
come up with it.
and
I just
57
watched.
minutes, and then we'll be
I listened to a heart surgery class.
That's you did. You did good.
surgeon class.
Exactly. Same thing like when you put a
that's right.
spinal in, you go in, like in the pregnant lady epidural, so you don't get those leaks.
Okay, the heart's beating. We're gonna and Mike's now gonna take him off pump. Heart's ejecting, filling up.
And so you can see your pulse pressure here is much more.
And look
normal.
at the level in the oxygenator. It's almost gone.
Mike runs them pretty low.
I turn the level sensor off, and then I go down to the bottom.
Look, he's getting ready to clamp
Yep.
it. He's gonna clamp it right here. There he goes.
We go
Boom.
off. We go off
He's
fast. We go off fast.
He is off.
Well, especially after a 3 hour.
Yeah, watch it, Patrick. Well, I did two surgeries on the same patient in 3 hours. Not bad.
That was outstanding. That was good. That was good stuff.
All right, so we're off pump. Good.
We're off pump. It gets better. Don't worry about those numbers right now for anybody out there that knows what they're looking at. They get better over time.
I don't panic about those. If you're looking at the heart, your TE shows
And
good
it's
function.
moving good.
That doesn't.
That's
it
all
used to
good.
bother me. It used to scare me to death. But
Mm-hmm.
I mean, me on aortics, I usually keep them 50, 60, 70 to make sure the suture line's not bleeding.
Mm-hmm. But this is, if you blow it up to 300, you might really do
I've
some
seen
trouble.
that.
Have some trouble.
You hear it popping, and there it goes.
Yep. So 3 hour pump run. This patient did great, right?
Yeah.
Once again, another example of not only excellent perfusion, but the value of the cardiopulmonary bypass circuit and
Oh yeah,
the
well,
perfusion.
good ultrafiltration. I mean, getting all those nasty cytokines and
Evil
inflammatory-
humors.
Yeah, out of there. I'm
We
a
didn't
big
even show
believer.
that. We used a
look
lot
at
of
that. Look at that EKG, super sharp.
Mm-hmm.
Yeah.
So, and that's 2 cross clamps, 2 cardioplegias, 3 hours on pump. I mean, you can't beat that.
Yeah, old lady.
Old lady who went home to do just fine and had a good time. So, Shelley, since this is your first time with us, what do you think?
That's great.
What do you think of the show?
I'm looking forward to seeing it on the other side and look at some of the ones you've done previously.
Yeah, we got a bunch.
18.
We have a bunch. We have a bunch.
It's a big resource.
Yeah.
It is, but it's been a lot of fun. Now, phone lines are open, right? Yep. So if anybody wants to call, we do have a question. Why did they stop distributing the Emblex cannula? Was one question, and I have another question which I answered from somebody in Puerto Rico that said, I think he's in Puerto Rico. Yeah, 787 area code. He asked, what was your temperature the first time he came off? I said 35. He said it looked like it was 31. So why don't you address that, and then Dr. Mettauer could address the Emblex. That's pretty cold to try to
Yeah,
come
well,
off.
the
we can go
first-
back to it on the film. I didn't
Well, I know what
look.
it was. It was I think the nasal was 35, but the bladder was 31. So we typically go by the nasopharyngeal, and if you shake up the bladder a little bit.
So you just basically didn't believe it.
Correct. And then you ask what the venous temp is, et cetera.
Right.
And if we're cold, I know some surgeons are impatient, but we start allowing the patient to eject more. And we may stay that way, low flow, but allow the patient to eject to warm the body up. And maybe adjust the nasopharyngeal temperature probe. And usually it's, if you've been warming for a while on a relatively normal sized patient,
especially a small
typically don't believe it. But before we come completely off, we'll make sure they're warm, because I keep my room super cold, which is
True.
it's like probably 54 in there.
It's
maybe.
sometimes
almost,
55, 54.
it's like, almost like a children's, but we have an underwater, under the
Body.
patient, underbody,
blanket trawl.
whatever it's called. Yeah.
That's what it's called. Okay. So Embelex.
Oh my gosh, you would. One, I think one of the reasons was they pulled it off the market was it didn't really show a decrease in stroke rate, which I don't agree with.
But that was done by Dr. Mack. That
I thought it
study.
had something to do with the coating. The heparin
yeah,
coating?
so that's So basically, it was heparin coated or heparin bonded, and when they released it, it got approved by the FDA, but then it had to be re-examined because of the heparin, and so they had to resubmit it. They had to resubmit it, and it became. And then the Mack paper came out that showed a trend toward reduced stroke, but it wasn't statistically significant. And the company, I honestly believe that Edwards was the margin for profit was pretty low, and they had some opposing forces, and they just said, okay, we're going to go where the money is, which is TAVR, in Intuity. I get it confused with Invuity, the light, but Intuity, and their newest valve, the Inspiris, and all that stuff. Those are the high market, high profit margin things. But it was the heparin concept, which was silly. I mean, how long has heparin been around and coded to things?
Well, I've never seen that confirmed. That's the story that I've heard.
No, it was on a release. It was on a press release. I remember I did a talk at your conference
in New
about
Orleans. That's right, or in Las Vegas when we were in Vegas. But I think I disagree with I mean, Dr. Mack's a great guy. He was one of our award recipients.
If you do enough of them, I'm convinced it'll be statistically significant.
Well, I think the reason it came out was because, of course, he's a very big TAVR proponent.
Correct.
And I think that, there was a push with the new classification for stroke, class 1 and class 2. And that if you look at TAVR patients, 90+%, up to 100%, really, have a new lesion by diffusion weighted MRI. So in essence, they now have to consult patients and tell them that your stroke rate is for class 1 X%, but for class 2, and what a class 2 stroke is, it's nearing 100%.
Right.
And the argument
and
was,
we don't know what that means long term.
But we don't check that with heart surgery. So the whole argument here was, does the Embelex, interestingly enough, almost all of them had some debris, but yet it didn't.
I sent every one of mine,
had
probably
something.
300 for a couple of years.
Had something.
And they all had something.
Yeah, and I just find that amazing. I mean, certainly whatever was captured, that didn't cause a stroke. And that you don't know which one is going to be the clinical stroke.
And there might have been some from putting the filter in. You don't know. I mean, I didn't do transcranial Doppler on those either.
Right.
I was putting
what do you think of that? You think we should be doing that on every heart case, every pump case?
I think so.
I think so too.
I mean,
what do you think, Patrick?
What, using the
TCD?
Oh, yes,
versus,
I do
versus
because it's an indicator
cerebral
of
oximetry.
Yeah. We should, definitely.
Shelley, your thoughts?
We do it. I mean, we do it on a lot of our patients. So
TCD?
No, there's a difference.
We use
TCD is
Transcranial Doppler.
It's not the cerebral oximetry.
Right, we do cerebral oximetry. Right, you do that. Right. Mm-hmm. So do you see this, where do you see this technique coming into play in your world? Do you have any thoughts in your mind about what next project you and Patrick can maybe collaborate on to develop even more of this information?
Yeah, we were talking about it at the break. Being able to put all this up and actually let your scrub nurse, your circulating nurse see all this, have the conversations with perfusion to support that. been doing hearts for about 25 years. And, so much of it's you go up there and you learn a routine. And once you've learned the routine, then is when, that's exactly right. You don't necessarily know the why. You learn the routine and then you start learning the why. And then once you've got that down, then you can actually, focus on and learn why you're doing what you're doing. This allows you to learn why you're doing what you're doing before. And I just think it just makes, make it so much.
Well, and you guys have a pretty nice setup there where there's that little table where you get most of it's kind of hokey, to be honest with you. The little poster board things where you, look at this and sign this and got checked off on it, like how to wash your hands and stuff. You can have a monitor up there.
Yes.
Like a 10-minute thing on, and you guys are sitting out there between cases sometimes or before cases, the perfusionists.
Where we're at, we actually have a little monitor board up there that we can play films on.
Right. And so that would be kind of
cool. So you said you've been doing hearts for 20, 25 years. So you started doing hearts when you were a candy striper, I'm assuming.
I wish.
That's what I think.
Thank you.
That's what I think. And anyway, if anybody wants to call in, now's your opportunity, because I think we're getting ready to call it a night. If you want to call in, do it now. But anyway, I hope everyone has enjoyed the show. I have. I feel like I've learned
I always
a
like
lot.
doing them.
Yes, and you do an exquisite job as well. I want to thank you, Shelley, so much for
Thanks
coming
for
here.
inviting me.
We really want to do more and open this up. I don't know who's out there in the audience just yet. We won't get that until we do the analytics as to how many were perfusionists, how many were nurses, how many were other things. We just don't know yet, but we'll figure that out. But we would really like to do some stuff and start becoming more and more inclusive, because I'm a firm believer that although you are the captain of the ship, you can't.
I don't want to be rowing though.
You can't sail.
So you can do the rowing.
You can't sail without a rudder, right? You got to have a rudder, and you got to have folks that are going to be the supporting cast. You can be the conductor of the symphony, but you got to have the instruments and the musicians that know how to play them.
I get
and that's what
This will allow me to do my job easier and make my job more perfect, so to speak. And every move I make makes his job easier.
Yes.
All of that results back to that patient.
That's right.
My job is to make his job seem seamless. He should not have to ask me for anything. I should be behind the scenes. He doesn't even have to know I'm there.
Because I'm starting to lose my verbal skills. It's more about signals and this and cautery and scissors. And,
Right, exactly. That's a very, very good point. But how much of this, too, do you think would be a benefit to both younger and older nurses who, the younger ones, to help stimulate keep their enthusiasm going, because you get a younger nurse and they have that youthful exuberance and they want to learn everything. And this can help perpetuate that. But also in the more experienced nurses who, we're the same way. We become somewhat, it's a job. I got to go do another case. And this gives you that renewed sense of enthusiasm, and gets you excited about what it is we do.
Well, you know what it is for me? Because I really don't have an assistant, I engage them.
Yes. And that's what this is intended to do.
I'm literally like, here, you're doing this part of it. You're doing that part,
Yes, that's right. You do that very well, actually, in the OR, is you do that. You include people and they're
not an instrument passer.
Correct.
I'm too cheap to hire a PA, so.
Correct.
I don't need one. These guys are great.
No, they are, actually. Yeah. I think they are, and I think that they truly enjoy it. And I think that learning is when you're learning new things, it makes going to work so much more enjoyable when you're stimulated by your job.
Right.
And that really does play a role in having, a good surgeon, a good leader in the room, somebody who's, because somebody has to be in charge. Otherwise, the ship's just going to be lost at sea. So there has to be somebody that's captain of the ship. And the things that we learn from you really help us to be able to do our job better. But it also makes us feel a part of the process. And that is in my view, critically important to building a team that is cohesive and is happy and is wanting to be there.
Right. Well, the surgeon also has to listen to his people too. You know, if the engine room's on fire, I need to listen to that and pay attention to that, right?
Sometimes, yes. Sometimes.
A lot
Now,
of
I know you.
surgeons have that problem.
I know you think that I'm just talking back there to hear myself talk, but I'm not. I'm really trying to tell you something. Shelley, you were trying to say something. You would keep.
I would agree if that was coming from Patrick. So let me ask you this real quick, just off subject, since we're winding up.
Yes.
How do you come up with all these topics? Do you get them suggestions from the Facebook people?
We do. Do
you give a list and what do they want to hear next? How do you move on to the next topic?
Very good point. Good question. So this particular project is Patrick's brainchild. Mm-hmm. So all of the credit, let's show Patrick on the screen right now. Put it right on him. Right? I want a close up of him. Tighten it up. Look at that. He was the brainchild of this project. Mm-hmm. Now, what we'll do tomorrow is send out evaluations for the program that we did on Tuesday and the one that we did tonight. And they'll evaluate this program. And one of the questions is, please let us know what you would like to hear about in future programs. Like one is, would you like to hear more about this? Would you like to see more of this? And then what other subjects? And so we take those and we also get them from the New Orleans conference and we select things out of there that seem more common. So if we get somebody that asks for something and it's only one person out of 300 and you ask, but there's 50 people that ask for something else, we're probably going to go towards that something else. But we consider all of them. So that's how we do it. And sometimes we just, I just think of something, or Patrick or somebody has an idea and they'll present it and I'll go, man, that's a really good idea. Yeah. And this was a great idea. I think this has been, for me, the best program we've ever done.
This started 6 months ago.
But a half a year putting this together. And again, I don't believe anybody has ever done this before. I do not believe this, as you see it up there, exists anywhere else. So
I'll trust you in that.
We're paving a path. Mm-hmm. Okay. Any final comments, Patrick?
We're out of time, but I was going to ask, is there anything that the perfusionist could do to make your job easier, or is there not?
To make my job easier?
Think about like when you're handing lines up or whatever.
No, I think, the group that we work with, again, we all work together enough that we kind of just read each other very well. So we've had a case where, wasn't going too well. It's, I need the lines up. Somebody's going to get them to you. We're going to have them prepared. Sometimes we prepare them. Sometimes our surgeon and us do it. So I don't think so. It seems to work really well what we've got.
Okay.
Not for me. That's your job.
Mm-hmm. Mm-hmm. It is.
Okay. Well, our next program, does anybody remember what our next program is? Our next program, let's see, I have to look it up. You guys talk for a second because I gotta look this up. I forgot to do it.
You doing any cases tomorrow?
Down in Northwest.
Oh, that's
Cell
you?
Saver.
Oh, okay. All right.
Well, I'm going to tell you while they're saying, we want to thank both of you, you and Sheldon, because this is your personal time to be here, and listen, it's a commitment. It's taking away time from your family, relaxing, doing whatever else you want to do. You seeing your family, if you remember where they are, we'll get you on Google Maps so you can get home because you probably haven't been there for a while. Shelley happens to live close to the studio, which we just found out, which is fantastic. So it won't be so hard for you to get here. And all, but we do appreciate you, and Patrick, you too, Magic, David, taking your time to do this in the evening. It's tough for everybody, but it shows your commitment in that the best way to show your commitment to your profession is by giving back, and it's really meaningful. And I personally appreciate all of you very, very much.